clinical outcomes. The frailty phenotype defines frailty as a distinct clinical syndrome meeting 3 or more of the 5 phenotype criteria, which include weakness, slowness, low level of physical activity, self-reported exhaustion, and unintentional weight loss. So here's some background and significance of frailty. The commonly accepted estimates of frailty prevalence range from 10% to 14% of the over 65-year-old population, and this increases with age. So it goes up to 25% in the age group of 85 and older. There's higher prevalence among women than men, and it's also been shown that frailty is most pronounced among those with lower education and income levels. So why is this important to us? Basically, there's some associations seen between frailty and functional impairment, fractures, hospital admissions, and disability. People who report frailty have more difficulty with mobility, performing housework, gardening, getting dressed, shopping, bathing, showering. Basically, ADLs and IADLs are affected if they are positive for frailty, and there's increasing evidence that frailty is not inevitable. It can be predicted, it can be delayed, and reversed to some degree. So this is my patient. She was a 82-year-old female, Panamanian descent. Here are her allergies: penicillin, levaquin, codeine, and her current medications. So basically, she was on ibuprofen for chronic knee pain. She has a history of some stress incontinence, low vitamin D level in the past. She takes her Xanax for some anxiety, but she says she usually only takes that in the evenings before bed, sometimes, not all the time, to help her sleep at night. She has a history of some cardiac palpitations, and her cardiologist had her on metoprolol just as needed if she was having palpitations and they were symptomatic. And she's diabetic, so her Januvia and her Lantus and glucophage for her diabetes, and HDTZ for her blood pressure. Health maintenance, disease prevention. She was up to date on immunizations that would be needed for her age group, which included her influenza vaccine, Prevnar, Pneumovax, and her shingles vaccine. She is also up to date on health maintenance as far as mammograms, colonoscopy, and yearly vision screenings. Past medical history. Of course, we talked earlier, hypertension, diabetes, some mild depression, anxiety. She has a renal mass, which is a cancer that was diagnosed last year, which is followed by a urologist. No treatment at this time. They are just monitoring it. History of sick sinus syndrome, bradycardia, intermittent palpitations, which she does see a cardiologist yearly for this as well. And again, the metoprolol was for it, treatment of it. Chronic fatigue and malaise, alpha thalassemia 1, vitamin D deficiency, osteoarthritis, and breast cancer in 2012, which she had a lumpectomy and radiation, no chemo. Surgical history, she's had cataract surgery, bilateral, again, lumpectomy, hysterectomy, and a history of a car accident with some fractures many years ago, and C-sections times 3. She has 3 adult children, all living. And she lives alone. She's a very independent lady. So, presentation of the patient with frailty. It is important to note that frailty can be hidden. It's a gradual deterioration of physiological reserves, which may go unnoticed if not specifically sought out, or go undetected due to presumptions that it's related to a chronic disease or disability. And so one of the easy ways to pretty much seek this out is to have them complete the simple frail questionnaire, which is what I did for this patient. There's a form, very simple. These are the questions that are asked. I let her complete it, and you can see where I put yes, these are the ones she answered yes to, which she said yes, she was fatigued. She did have more than 5 illnesses, and she had lost more than 5% of her body weight in the last 6 months. That was not intentional. And she pretty much related that to stress, because she's caring for her elderly mother who's 100. Her and her sisters take turns staying with her. And also, she's very compliant diabetic. She's very strict on what she eats and watches that closely, she said. Other questions that she reported no to were resistance. Cannot walk up one flight of stairs? She said she could. Aerobic, cannot walk one block? She said she could walk a block. And then if you score 3 or more, that equals frailty. 1 or 2 is pre-fail. So some common complaints that a person who is experiencing frailty may report is decreased energy, may tire easily after a few minutes of activity such as walking or cleaning up around the house, not having the strength to do things they once did, maybe like opening jars and things like that at home, decreased grip strength, may report not being able to get out and shop like they used to or keep up with family members when they're going out places. Subjective data, her review of systems, pertinent positives and negatives. These were her positives: fatigue, palpitations, hearing loss, knee pain, weight loss, depression, anxiety. Negatives, we went through every system, of course. Just want to make sure there's not something else going on that could be related to her fatigue, weight loss. Objective data, vital signs, and screening tools. Her vital signs were all normal. Other screening tools I did on the assessment was the hearing screen. She did wear bilateral hearing aids. She has for several years, but her screening was still poor. She was a 28, and a score of 26 to 40 suggests significant hearing handicap. And she even said, I can't even hear with my hearing aids. So that was something she was going to do, is follow up with her audiologist and have them look at the hearing aids and see if there's anything else that could be done to help with her hearing. She basically kind of just would look at you when you're talking to her and help by reading your lips. Simple frail questionnaire, again, we did it, and she was considered managing well. So basically people whose medical problems are well controlled but are not regularly active beyond routine walking. I completed the mini mental status exam on her. She scored a 28 out of 30, which was good. There was no clinical signs of impairment with her. Did the geriatric depression screen scale, which she reported depression, but she actually scored a 3, which does not suggest depression. I believe hers was more kind of a situational depression from having to care for her mom and some other family stressors she had going on. And then the Tinetti Balance Assessment tool, she scored a 26, which put her at low risk. Her main thing was her knee pain gave her some trouble, especially after sitting for a while and getting up to walk. She could really have some difficulty there with pain. Her physical exam, did a complete head-to-toe physical exam, highlighted some pertinence there. Of course, her hearing was an issue. I made sure that with her weight loss again and her fatigue that we didn't notice any lymphadenopathy or masses. Heart assessment was normal, cardiovascular was normal, abdomen assessment was normal, no masses, no tenderness. And her gait, she was steady without devices, but occasional limp noted on the right side due to knee pain. And then her get up and go was 13 seconds. She was slower to get up out of the chair and used the arms as assistance to rise. Complains of pain in the right knee when going from sitting to standing. Performed the rest of the test without any difficulty. Then I did also the mini mental status exam, which we talked about earlier. She had a 28, which was a good report for her. Okay, objective data, diagnostics and labs. So this is what we ordered: CBC, CMP, hemoglobin, vitamin D, UA, which she had trace hematuria, which is chronic for her, and it's followed by her urologist. Lipids were normal, TSH and T4 were normal. So all of her lab work was pretty good. Her A1C was even 6.2. We did not do any diagnostics on this visit, such as x-ray, CTs, or MRI. She did have a history of x-rays of her knees, which showed some osteoarthritis in the past, which was causing her knee pain. But these are additional tests that could be considered for any patient you may feel like is having an issue with frailty, and you just want to make sure that we're ruling out any other injuries or disease processes that could be contributing to their symptoms. So final diagnosis and why we chose this was chronic fatigue and malaise. Basically chose it because we ruled out everything else. Wanted to make sure that she didn't have thyroid issue. Her TSH and T4 were normal. Wanted to make sure she wasn't anemic. Which she was not. Hemoglobin, hematocrit were normal. She does have a history of vitamin D deficiency, but her vitamin D level was within normal limits on this visit. So the plan, so what we would do for her, what we did is I talked to her in depth about just knowing her limitations physically and mentally when caring for her mom and taking time for herself. We talked about her risk of falls and that the best way to help that was by going for a walk, 30 minutes each day, do some strength training exercises, balance exercises 2 to 3 times per week. And this can not only help her strength and endurance, but also her mental health as well. We talked about not skipping meals, making sure she eats healthy breakfast, lunch, and dinner with, a good combination of fruits, veggies, protein, complex carbs. And if she needed to, that she could, even drink like a Boost that had some protein in it. And that she didn't have to control her blood sugar as tightly as maybe she once had, especially if at any point she was experiencing hypoglycemia. The next set here are the evidence-based recommendations for treatment of frailty, which should aim to prevent, delay, reverse, or reduce the severity of frailty and prevent or reduce adverse health outcomes in those whose frailty is not reversible. Exercise is the interventional modality that has the most consistent benefit in treating frailty and its key components. Exercise has good impacts on all organ systems, especially musculoskeletal, endocrine, immune. Another important area of intervention is to prevent biological, socioeconomic, and environmental stressors and improve clinical outcomes. And the main challenge barriers for this plan for this patient was just the lack of time to exercise due to her, having to help care for her elderly mother. Community resources, a great resource for frailty would be physical therapy if they can go. They can teach them, strength training exercises. And if they can't go to PT all the time, then they can even be taught exercises to be done at home, or they could go to a local gym or a senior center. She could also benefit from working with a nutritionist who could teach her, make sure she's just consuming adequate amount of calories and protein. Multidisciplinary health team, again, PT and nutritionist. She needs to continue to follow with her cardiologist and urologist, and other patients that you may be seeing could benefit from a geriatrician, a social worker, pharmacist, occupational, and physical therapist as well. So health behaviors that were identified in this case study, hers were lack of exercise strength training, strict adherence to dietary choices to control her blood sugar, and increased stress related to caring for her elderly mother. And we talked about that too, as far as maybe her and her family having somebody come into the house to help with her mom so that they could have time away. That was not something that her family was agreeable to at this time. Social determinants. Again, at the time she has to spend taking care of her mom, and she had reported some feeling of isolation from having to just be there all the time and not being able to spend time with other friends and family members. Socioeconomic issues and cultural issues, she has a fixed income. Cultural issues, again, family was not acceptable to having someone come in help the mother. And there was no legal or ethical issues considered at this time for this particular case. So conclusion, one of the most important things I learned is that frailty is not inevitable aging process, but we can do things to prevent it, to correct it, to slow it down. Goals for patients with frailty include improved physical and psychological function, reduce hospitalizations, and reference.